Welcome to this fourth PCR webinar dedicated on left main disease. This is specifically focused on PCI of calcified left main stenosis, how to safely perform percutaneous revascularization. My name is Emanuele Barbato from Naples in Italy, and I have the pleasure to have with me two expert operators, two friends, Christopher Naber from Zurich in Switzerland and Flavio Ribichini from Verona in Italy. Let's go to the learning objective of our webinar today. We are here to evaluate the procedure-related risk of patients with unprotected left main stenosis. We want to plan optimal PCI strategy in patients with heavily calcified left main lesion. We want to learn how to rotablation, how to safely perform rotablation in left main disease. But let's immediately look at what we are talking about. I would like now you to look carefully at this video clip, reflect on this image, and share with us what is the first thing you normally do when you see this image in your lab. Take your time. But let me start from our colleagues here in the room. What would be your first reaction, Christoph, when you see this image in your cath lab?
Well, Emanuele, honestly, the first reaction is I look at the anatomy and start to analyze. But I think especially in these severely diseased patients, we should see the patient behind the anatomy.
That's a very good point. Flavio, actually, it was you who did this case in your lab a couple of years ago, so you know very well the case. That's why I'm very curious, I'm very intrigued to know what was your first reaction when you saw this coronary angiogram?
Well, the first reaction I have when I have in front of the screen such an ugly image of a tight lesion of the left main is looking at the screen of the monitor and checking for the blood pressure and the heart rate of the patient. And then if everything is fine and normal, I look at the patient, I smile to him and try to make things calm and easy. But my first thought in a case like this, with these nice distal vessels and this such complex and tight and calcified left main, is about surgery.
That's actually a very good point. Both of you shared important points. And I like what you just mentioned, Christoph. For a moment, we forget to be what we are. We don't look anymore at the image, but we remember that behind the image there is a patient. And this is a particular case where it is critical to know more clinical information about the patient, really to know which kind of decision we have to take in this case. Flavio, would you mind to introduce the clinical scenario here?
As I said, this is a patient we had 2 years ago, or more than 2 years ago. He was sent to our hospital because of a long-lasting history of typical chest pain under effort that he had for more than 4 or 5 years. He's a former military, retired, age 85, and in very, very good general conditions, very fit, still training, and he was reducing his daily exercise because of the chest pain. At the time he decided to come to the hospital, he was already in a class 3 to 4, because some chest pain could also happen at staying at rest. He had no other comorbidities, normal LV function over 60% ejection fraction, normal glomerular filtration rate, no distal disease of the peripheral circulation. So globally, a very nice patient, low risk except for age and this low threshold of angina that sometimes could be considered even at rest. This is a situation in which surgery and PCI can be discussed, and this is the situation in which scores and discussion in the heart team are essential. And this is what we did, because my first temptation was to call the surgeon. And as you cannot see that from the image because you see a guided catheter already, but he had a diagnostic angiogram, and he was advised to talk to the referring physician to convince him to undergo surgery. And, but there was absolutely no way to convince this gentleman who said himself, I am 85 years old, I don't need to live other 10 years, so I don't want to undergo surgery. And as you can see, the scores give the right to what he's saying, because the predicted mortality at 4 years for syntax score 2 is much higher with surgery than with PCI. On the other side, the angiographic analysis shows a very low syntax score, which makes this patient apparently a good candidate for PCI of the left main. But I'm convinced that this angiographic evaluation of this left main underestimates the risk that might be behind this extremely calcified bifurcation, just because the lesions are short, the vessels are big, and the distality are good.
Right. Flavio mentioned 2 or 3 important points now. Well, first of all, how to deal with this complex situation. In his case, he had to take the patient off the table. He had the time to discuss potential procedure with the patients, with the heart team, and he even took the time to calculate scores. What is your consideration about all this in your practice?
Well, I think for sure you have to take the patient off the table in this situation. There's nothing urgent, and this is a critical decision that has to be taken. So you need to inform all parties that are part of this decision, which is the surgeons, which is you, and which is finally the patient, because the patient will take, as Flavio just showed in his case, a big part in this decision. And scores are good. I mean, scores are helpful because all the parameters that are in scores are finally also a basis for our decision making. But scores cannot be the only tool to make the decision. At the end, it's a decision that needs to be taken integrating all these parameters.
That's a good point. Flavio, tell the truth. Do you calculate scores all the time? How do you behave, or do you just did that for the sake of this
Sincerely,
webinar?
not all the time, not in all cases. This is really a case in which you see a good surgical candidate who is aged, so in the end, the risk is not low, and the life expectancy is not what you want to offer to a surgical candidate. On the other side, you have apparently a low syntax score, but as I said before, the complexity of this left main might be unexpectedly difficult. And so the scores in these patients are telling that he might be a good percutaneous candidate, provided that you know what you are going to do. And this is what we are going to discuss now.
That's an excellent point. So just to summarize, we agreed that scores might be useful, not in every situation, but in situations like this one, where you have to balance the local experience of both the interventional cardiologist and the cardiac surgeon, scores might give you a good indication on which side the balance just moved. But let's say we are in the labs of 2 experienced operators, so I have no doubt on the ability, on the skills of our interventional cardiologists today in the panel, and there is a consensus to go on and perform percutaneous coronary intervention. Let's then just walk through additional angios of this patient. This is a caudal view. We can have a clear insight on this bifurcation, and we see that it is a true bifurcation lesion here. Both distal left main, proximal circumflex are involved, and there is even an additional bifurcation stenosis just beyond the ostium of the circumflex in the proximal to mid circumflex. Let's see another video clip. There we go. We see a cranial view here, very tight distal left main stenosis, and there is even a sluggish flow on this LAD. So I wonder how this patient managed to be relatively stable all the time. And here we have again the initial video clip where we have a summary of all the information we just shared. So before going on and discussing about the procedures in itself, there is one question from the colleagues from the community. Did this kind of patient, was this kind of patient included in the syntax trial? He's 85 years old.
Sincerely, I don't remember if there was an age limitation in the syntax first trial.
Yeah, well, I'm not even sure.
Question. I don't remember. I would say there was no limit.
Okay.
If the patient was, I remember that was the first heart team test, because the case was supposed to be discussed by both interventionalists and surgeons. Yeah. And if he was deemed to be a good candidate for either therapy, the patient was enrolled. I really don't remember, because in my center, we did not participate in the syntax. We did enroll many patients in Excel trial, and there was not a limit of age. It was just a consensus. If the patient was accepted, was enrolled. But in the syntax, I don't remember.
Chris, let's now discuss about the PCI strategy. So very ABC, what would be your preferred access? What would be the guiding catheter size? Which kind of guiding catheters? 1 wire, 2 wires? What is your strategy here?
Well, you know, this is you can do this case radial, but honestly, since there's a high degree of complexity, it's a lot of calcium, it's really bulky calcium. I think it could be that whatever happens, I would be happy for an extra reserve, for extra support. So I think I would choose a femoral route in this patient. I would like to have a 7 French. I would like to have a kind of XPU guiding. So all the support I can have from the guiding. And for sure, at the end, I would use 2 wires. I mean, in all bifurcations, we should use 2 wires if we think we should protect the side branch. And the left main is a specific bifurcation where no side branch is not important. So 2 wires, 7 French femoral.
Flavio, I already see here a guiding catheter coming from the femoral approach. Any argument against radial approach in this case?
No, nothing against. I mean, radial is our default approach in 90% of cases. In this specific case, I agree with Chris. I decided to use a 7 French because you might need a large bar for making the rotation. There is another issue. I mean, this patient might need a temporary pacemaker in the right ventricle, so you need to work on the groin. And I wouldn't exclude that you might need circulatory support, and this will go for the groin. So at the time you're working on the groin, working with 1 or 2 groins is more comfortable than having a hand and a groin. So that was putting all this together as we went through the femoral with a 7 French extra backup catheter.
Perhaps before wrapping up, what is your preferred strategy here? Would you mind, Flavio, to share with us this information? Was there any sign of left main stenosis on his ECG? We didn't show electrocardiogram of this patient. How was this?
Totally normal.
Totally normal.
Totally normal.
That's a good point. So I think there is consensus here. Femoral approach, bigger than 6 French, 7, 8 French, depending on what you have in the lab.
You don't need. Actually, there is no reason to use 8. You just give more contrast, and you make a bigger hole in the femoral, but any kind of rotablation device will go through the 7, and you can do any kind of bifurcation technique. I disadvise to use the 8, but the 7 is...
And we go for 2 wires for sure.
Yeah.
Chris, do you think the balloon will cross in this tight lesion here?
Actually, I think so, but the question is a balloon enough for these patients? Because if I look at the angio, this looks like very eccentric, heavily calcified, bulky calcified disease. So I think the balloon will cross, but I think there's good reasons for rotablation here.
Flavio, how about you?
Well, my point is not if the balloon will cross, if the stent will cross, and if the stent will expand. So we have to think about, in the planning, we have to think at the final result we aim to get. And so I wouldn't go with the balloon if I have the needed technology. In the case like this, I would start from the beginning with rotational atherectomy.
I see that the colleagues are already warming up. We have several questions here that we might address while talking, because the next point I have to you is the following one. We agreed that this is a very complex case. The anatomy is complex in this case, not because the disease is too much extensive. After all, these are focal lesions, if we may say so. Do we need hemodynamic support? That is also a question coming from the colleagues. What is your position on that, Chris?
I think in this specific case, I have a very healthy gentleman, I have a good left ventricular function, and I have a relatively focal disease. Honestly, I think I would not decide on hemodynamic support in this patient. I think this is a case where we need to follow a plan and be as fast as we can, and this will be enough.
What is your position here, Flavio?
Well, I was reading the questions from the colleagues. I mean, they hit the 3 main issues of our discussion: IVUS, rotablation, and LV support. Regarding the LV support, I have a quite low threshold to start with LV support, because LV support should be started before, if you think it's necessary. Running after the hemodynamic crash as a bailout is already a complication. I mean, you failed already in your planning. In this specific case, with normal LV function, and even more important, with normal systolic blood pressure, the patient had 130, 140 millimeters of mercury. When you have normal pressure, you don't need it beforehand. It might be that he will develop hypotension during the procedure, but you can control this with drugs. I'd never start this procedure without support if the pressure is below 100. But in this case, I wouldn't.
In this specific case, you would not use hemodynamic support, and these are the points you just summarized for us that we listed up on this slide.
We have normal LV function, blood pressure over 120, no functional MR, and you have a stable cardiac rhythm, no tachycardia.
Let's assume now, Flavio, let's stay with you, that I want to know from you what are your cases, what are the patients where you would consider hemodynamic support?
Well, we have a specific algorithm in our center, and as you can see, any patient having a moderate to severe dysfunction, which is below 40, 38, 35, anything below 40 will deserve at least a balloon pump. Especially if blood pressure, it's not that much more than 100 millimeters of mercury, and if you have secondary LV dilatation and moderate MR. What is even more indicated is when you go with blood pressure below 100. I would never touch electively, not in an emergency, electively a left main like this with a systemic blood pressure below 100 or needing inotropes to reach 100. In this case, I would go with more aggressive support like an Impella pump, or as one of the colleagues asked there, with an ECMO. ECMO is very effective, but it's very aggressive. I would reserve the ECMO for blood pressure even below 80.
Thank you. I think we have other questions here. Just quickly, how frequently you see this patient in your practice? Do you see once a month a patient like this, Chris, or less than once a month?
Well, if you look at distal left mania, you see it even more than that. I mean, this is an exceptional case because of the extent of calcium, the massive disease. Otherwise, you see distal left main cases. Meanwhile, I see once a week.
How about you, Flavio? How frequently see this patient, this specific patient?
These kind of patients, no, these are 3 to 5 in a year, sincerely.
Okay. Let's go now back to the angiogram. So we agreed that this is a complex case. We have agreed upon the strategy. We go femoral, 7 French. We take a guiding catheter with good support. I see that you have taken here an extra backup catheter. We agree on 2-wire strategy. I could read between your words that we have a preference for rotational atherectomy in this case, but let's first analyze the angiogram. We have a true bifurcation here, a Medina 1-1-1. There is calcium plus in this case, short lesions as we said before. The good news is that we are dealing with large vessels, at least the landing zones look like to be of large diameter. There's no diffuse disease, and there's this additional bifurcation that we have to deal with on the proximal circumflex. What we haven't seen and what we will not show in this set of slides is the right coronary artery, but we have learned from Flavio that the right was small and free of disease. So that is not of our concern. And here I want to come back to you, Christoph, and it was also one of the questions from the colleague. Is the angio enough to take decision here as to which revascularization strategy to perform? In our case, we decided PCI. But then the next step would be, do we need IVUS to move on and do our PCI?
Well, you know, I always believe that when you use a tool, you need to have a precise question. And so I think in this case, we have many questions. We want really to understand if the centricity of the calcium is like we anticipate. We want to understand where the disease starts, where it ends. Maybe we would like to learn something about the circumflex ostium. So I think there are many reasons to use imaging in this case, and I would strongly vote for that.
Flavio, what is your opinion? And first of all, do you think that the IVUS catheter will cross this stenosis?
If I should make a guess, I would say it will not. But I agree with all what he says. I wouldn't add any other reason to use it, but are very good reasons to start with an IVUS.
I think that you performed IVUS in this case, and by the way, IVUS will also help us to address a couple of questions that came from the colleague, but we'll come back on this in a while. So, can you comment on this image?
Yes, well, to my surprise, the IVUS probe went through the left main stenosis to the LAD, and what you see on the bottom right part of the screen is the pullback from the LAD to the left main. We have saved some still frames to show you some of the specific questions that we want to answer with the IVUS. One is the distribution of calcium. You can see from the bottom left image and the central image that the distribution of the calcium is over 180 degrees, but that is totally asymmetric. So this makes this kind of plaque even more dangerous when you expand it, if you want to expand it high pressures with balloon or with a stent and post-dilate the stent. Then another good news is that the distal part of the LAD, it's as expected from the angio, which is not always the case. It's a good vessel with a good diameter and not a diffuse disease. Then, as you can see, we crossed with the probe also in the circ for the same reasons. And this image is even a little more, I'd say, disquieting. You see that the distal part of the circ is a big vessel. It's good quality. It's good news that the origin of the oblique marginal is free. So this is good information we will take in consideration. But you see how much calcium you have at the point of the bifurcation, and especially in the body of the left main at the point of the minor lumen diameter, which is very tight and again very asymmetric and deep distribution of the calcium. We can see the shadow cone, which is at least half of the circumferential area of the left main.
These are very nice images. Let me just summarize. Here we have seen a lot of calcium, tight stenosis. I didn't have the impression there was circumferential calcium, and this might explain also the reason why our probe could relatively easily cross this stenosis, both in the direction of the LAD and in the direction of the circumflex. For sure, there is calcium for more than 180 degrees. More than 2 quadrants are involved with calcium. So the next question would be how much these images might impact our procedural strategy. I fully agree that if there is one setting where we really need in our practice imaging guidance, in this case you used IVUS, it's a distal left main, OCT might equally have done well. But I think we do have to strongly recommend the use of imaging in this kind of lesion. And by the way, guidelines are also supporting this with a class of recommendation 2A. Christoph, in your practice, what is your position about using imaging in this setting?
Well, I already said, if I have a precise question, and here I had enough questions, it is something that I think we should use. If you have no questions, so I'm not using it in every case. And in particular, in this case, there's no really new information from imaging, but the imaging really confirms what we have thought from the angio. So now we know that our analysis was correct.
Flavio, how did this intravascular imaging impact your decision? And I want to reconnect with one of the questions done by the colleagues. In other words, were this image convincing to you to choose, for example, rotational atherectomy over cutting balloon, because cutting was one of the questions of the colleagues, or you had already your idea clear in mind before doing that?
No, definitely. There is a really very tight MLD before the bifurcation of the left main. Think about this. This will be issue of discussion on how to rotate this lesion. There is a lot of calcium in the bifurcation. We will very likely need to put 2 stents. And I am anticipating a little bit my opinion on how to deal with this bifurcation. And 2 stents, we all know, have a higher risk of thrombosis, a higher risk of restenosis. So the best we can do is to obtain the maximum expansion of the stents. And this is something you will obtain with a good lesion preparation.
Thank you very much, because you're already alluding to the stenting strategy, so you would opt for a 2 stenting strategy. We will come back on this later during the webinar. There is also a specific question on this, but let's keep going on the current flow. Now I want to discuss about the plaque modification strategy, more specifically because I understand that your preference goes for rotational atherectomy. I would like, Flavio, you to address the following points. When we discuss about rotational atherectomy in general, but specifically in this patient with distal left main stenosis, the questions I have to you is rota wire positioning, 1, 2 wires, and if 1 or 2 wires, which one would you place first and in which vessel? Bar size to start with, And finally, rotational atherectomy technique with reference to bar movement and speed.
Okay. These are very practical issues and very baseline. First of all, the rotawire has to be positioned as far as possible, because you will need support, and sometimes doing the rotation in these very tight lesions, the wires come back. So my decision is to treat first the most important vessel, and for sure LAD is always the most important vessel in a patient that has viability in all his walls of the left ventricle. The bar size always start with the small bar size, because this reduces the risk of microembolization and low flow, and in the left main this may cause hypotension, and before the patient's feeling bad, the operator will feel bad and the team will feel bad. So you have to work beforehand to keep your procedure under control. Another reason to use small bar is that the risk of getting the bar entrapped, which is something of the dreadful things we don't want to happen, is higher with bigger bars.
Flavio, so let me interrupt. When you say small bar size, can you give us a number? In this specific case, which bar size would you use?
Well, the smallest we have in the market is the 1.25. But this is a very big left main and a very big LAD. So in this case, I would start with a 1.5, okay, with the option of upgrading
to a bigger one. I'm curious to hear what is in Chris' opinion. What would be your rotablation strategy here?
Well, I basically agree on everything that was just said. And 1.5 is for let's say, for most vessels, it's my default size. Mm-hmm. So I must have a good reasoning to choose a bigger size to start with, or a good reasoning to start with a smaller size. 1.5, I think, is a good starting point for many vessels.
Let's see what Flavio has used in this case. Let me go on to the next slide. So here, as far as I can see, you started with a 1.5 millimeter bar, Flavio, and you started with this technique of performing rotablator. Can you comment on that?
Well, there is discussion on how to do this. I like this picking technique. You see that the bar is going and touching the tightest part of the lesion and coming back, almost like not willing to cross it. And this is exactly the idea, not willing to cross it soon. Sometimes it goes. It means that your bar was small or there was less calcium that you expected. But sometimes it takes a lot of time, and you never need to hurry, because this enhances the risk of getting your bar entrapped. So
I think the problem is also, Flavio, when you go too fast, as you just said, this is problematic, because then you might get stuck in the lesion, because on the back side of your bar you don't have diamonds, so you cannot go back.
And then you are in trouble.
So here I see first advancement. Let's move on. And here you say after several rotations, so after several attempts with 1.5, the bar eventually crosses. Is it necessary to do several attempts?
I prefer doing short periods, so you don't have a very important increment in temperature, you don't embolize that much. Sometimes the patient has a little bit of hypotension. You wait until he recovers blood pressure. You can give some drops of dopamine or dobutamine, whatever you want, so you keep the procedure hemodynamically under control. Never hurry, never try to cross immediately. Take your time.
And what are your considerations on the speed, on the burst speed?
I like high speeds. High speeds, it's for me above 16, 1700,000. This is what I routinely use in these very tight lesions with a small bar.
Then let's see the angiographic result after the first ablation run of series of run with 1.5 millimeter bar. And this is the angiographic result. What do you think, Chris? Are you happy with that?
Well, you know, completely irrespective of the result, because very often you will not see too much. Especially in this big vessel, we have to consider if we need to upsize the bar. So I'm happy with the result. I see a little bit slow flow in the LAD, which I think is still okay. The patient had no pain at this moment.
Pain. Probably he has a long-lasting ischemia, so he had a kind of preconditioning. No chest pain, no ST depression.
But what I think is what I would do most likely, because it's a big left main, it's big proximal vessels, I think we should upsize at least one step, 1.75.
Flavio, before going on and tell us what you have done in this case, can you remind which kind of rotawire did you place in this vessel?
This is a floppy. It's the easier to manage with, and you don't need an extra support wire in a case like this.
Okay, let's see what you did next. you upsized to 175.
Yes, I think the lesion was so tight that you really want to open it. You need to think about the stents. You are very likely going to use 2 stents. And it's a big vessel. It's a large left main, and there were no hemodynamic problems after the first rod ablation. So 175 is what you ideally should aim when you do a large left main like this.
And much like before, you just applied the same technique. You first did a first run and then sequential runs until your bar did not get across.
Because the fact that the first didn't get entrapped doesn't mean that the second will not. So that's the same caution, same technique.
That's a very important point. Let's see what was the angiographic result after the 175 millimeter bar. And again, the question goes to you, Chris. Happy now with the result?
Yeah, I'm happy. I mean, I see the flow even improved in the LAD. And again, I wouldn't take the angiographic result as the question if I should now upsize. I know the vessel size. I think 2 millimeter bar is a little bit aggressive, so I would stick with 1.75. And you need to think what you want to do now. Either you now start the intervention on the distal left main, or what you could decide, and this is where the IVUS gave us some insight, I think you could decide even to do some rotablation on the circumflex, because the circumflex ostium was really, really tight.
What did you do, Flavio, actually next?
Well, you know, one of the reasons why rotablation is good in bifurcations is because it kept the side branch safely open. I would say always, but never is always or never. Almost most of the cases, rotablations does not impair the side branch. And this is the bifurcation. So after this 1.75 in the left main LAD, I removed the wire from the LAD and put a wire, a rota wire on the circumflex.
Why, Flavio? Can I ask you very simplistically?
Yeah, this is a rotational device. So all what rotates will make a mess if you put 2 wires. It might happen that in a large vessel you can do it, but we strongly disadvise to do this. So 1 wire per vessel and 1 wire per rotation. So you see that there is a floppy wire on the circ, and the wire from the LED is going out.
Can I ask you whether there was a reason behind that? I mean, couldn't you have just pulled back the rotor wire from the LED and redirected to the circ?
Wow, this is difficult. I mean, the wire is not an easy wire to use. It might work, but it's difficult.
Okay, let's go next and see what you did here.
This is the rotation with the 1.75 from the left main to the circ, which has a totally different angulation. And so the ablation of the calcium that you will exert in this part of the bifurcation is completely different. So I had the feeling, even pushing always very cautiously, as you can see with the peak of movement, that the rotation ablates the calcium in a different way. So you are making this channel into the left main larger.
Chris, do you agree to start with a 175 as a first bar on the circumflex?
Well, in this specific case, I think you can, because you already crossed the main lesion. On the other hand, we know that the circumflex is tight. Let's say what I would normally do would maybe start with the 1.5 again, but I can understand that you tried it.
If I may share my humble opinion, I wouldn't have started from a 175 going to the direction of the circ, for a simple reason that I don't have the large experience that Flavio has. And I think we have to be fair also with the colleagues who are following us from home. Circumflex with such an angle might be a reason for bar trapping, especially if your bar is bulky and the lesion is not well prepared. So if you are confident enough and you have the experience of Flavio or of Chris, you can do this. But if you are less experienced, my advice would be just repeat the same protocol you applied from left main to LAD. Start small and go bigger. So let's see. The first attempt didn't go easily through, Flavio. Let's see what you did next.
Again, with patience and with a peak of movement until it goes.
Nice. Goes very smoothly.
And you see that the rotation goes beyond the origin of the first oblique marginal, because this is another bifurcation. There was not a lot of calcium there. It was mainly fibrotic, but we are preparing also the lesion for the second bifurcation on the circ.
Chris, I will not show you a control angiography. We are doing the procedures all together. We want to optimize contrast, but we have seen how the bar moves now. Is there any need to do further plaque modification here?
Honestly, yeah, I think you say the right thing. It's plaque modification. We are not, not digging a tunnel or something. We are modifying the plaque and then try to open the plaque with, for example, non-compliant balloons. So I think there's really use for a 2-0 bar. You can, but in this case, I wouldn't.
Okay, let's go next. And this is what actually Flavio did. He stopped rotational atherectomy and he moved to a balloon. When we discuss about balloon, Flavio, what was your preference here?
Well, here I put again two regular 0.14 wires. And what I do after rod ablation in this case is what I call balloon testing. You open up a 3.0 balloon, non-compliant, in the nominal pressure, and you see if it is well expanded. A 3.0 balloon well expanded tells you that your stents will go through smoothly. Even more if you use a 3.5 balloon, which is a little bit aggressive if you want after a rotational atherectomy. But again, staying at the nominal pressure of the balloon, you see how nicely they open. So you have the certainty that your stents will go, which doesn't mean that will expand perfectly, but at least you will not have troubles in pushing and damaging the stent structure when you will do the double stent.
Which kind of balloons did you take here? Non-compliant?
Non-compliant 3.0 and 3.5.
There was one of the questions from the colleagues about the role of scoring balloon, cutting balloon. We might discuss this later, but just quick answer from both of you. Is there any role for scoring cutting at this stage of the procedure? Is there any role for scoring and cutting at the beginning of PCI? So instead of doing a rod ablation procedure, do you think that scoring cutting would have had a role in the beginning? Quick answer from both of you.
I don't use them. I mean, they have a bulky profile, it's difficult to cross, but at this stage, no reason. After rod ablation, no reason.
Well, if I look at this case, I don't believe you could achieve a good result with a scoring or cutting balloon. I think this is a rod ablation case, and at this stage, the plaque is modified, so no use for me.
I need to show you now the angiographic result after this extensive plaque modification achieved with both rotational atherectomy up to 175 millimeter bar in both branches and with additional balloon dilatation. It looks like completely messed up, isn't it? What is your idea now, Chris? Do you need to do anything else before stenting?
No, I think, the point is we have for sure we have this section. We have almost a hematoma in the LAD, but I think we've seen that relatively big balloons, 3.5 for proximal LAD is good, opened up nicely. I think the next way should be to proceed with stenting for me.
And if we now want to discuss about stenting strategy, in this way we will also address one of the comments of the colleagues. What would be your main vessel to target? I mean, would you stent left main circumflex, left main LAD? What is your preferred strategy here?
Well, the main vessel for me, this is a huge circumflex by the way, but the main vessel is still also the LAD. So it's always difficult to tell in a left main. In this particular case, from the pure anatomy of the bifurcation, you could do almost any bifurcation double stent technique. There's no difficulty with that. The consideration that I would have is that in case you do something like a mini crush or you do something like a tap technique, you will end with the most sensible zone of your intervention, which is the neocarina or the crushed part, exactly where the big chunk of calcium is. So I think since we have two vessels who are close in size, we have a good angle. I think culotte could be a very good choice in this patient. So
two stenting technique, culotte, that would be your preferred strategy. Let's see what Flavio did. Can you tell us what you did here, Flavio?
Well, I agree that the main vessel is the LAD. And the one really needing a stent is the LAD, because the dissection is quite deep and you have this shadow which is not nice to see on top of the proximal LAD. But as you see, there is the bend to the circ is much more pronounced. And after implanting the stent on the circ, I thought that it was really straightforward to go to the LAD. It's not 90 degrees bifurcation, but it's about 75, 80. So in the occasion of a culotte, that I agree would be a very nice technique for this case, I thought it was easier to cross the stent to go straight to the LAD.
I think it's remarkable, Flavio. I will see how the stents cross here. Severely calcified, but after rotablation, very nice crossing of the stents.
That's a very important point. I mean, you make this navigation very smooth despite the bend, the calcium, the bifurcation, and this is a very large stent. It's a 5.026 millimeters.
That's large.
I have a question now regarding the stent size. That, by the way, was also one of the points made by the colleagues. And when addressing this question, please tell me whether IVUS, and this is more to you, Flavio, had any impact on your stent size. Because, of course, you did IVUS, you might have performed your measurement. You went here for a 5 millimeter stent. I'm sure you thought to the proximal landing zone of the stent, to the left main, right? But if I look at this circumflex, at least angiographically, it doesn't seem to be 5. So can you share what was the decision strategy there?
I saw the question on the screen. It's a very good point, asking whether we made measurements. I will tell absolutely the truth, we didn't, because we know it's a tight lesion of the left main. I mean, we don't care how small it is. What we want to know is how big it has to become. And we know that the diameter of the left main is 6 millimeters, and the distal part of the circ is 4. This is why I took a 5. It's something in between the 4 and the 6. And my aim will be to remain below 5, so expanding the stent at, I'd say, nominal pressure and no overexpanding the exit of the stent, but being more aggressive in the proximal to reach the 6
millimeters. Let me hear what Chris thinks about it. What would be your size?
Honestly, Flavio, I disagree in this point. I think I would choose according to the circumflex, which would be then the distality. And I think this makes, for me, a lot of sense, because the modern stents, you're very variable with size. So I might have chosen maybe even only a 3.5 and then would have upsized with balloons afterwards.
Well, I want to quickly go back to Flavio. Just quick answer. In case your main vessel was the LAD, instead of the circ, I'm sure here you might have thought, after all, I have a straight segment, and if I end up with a distal dissection there, I can have easy life to advance an additional stent and fix the dissection. But if your landing zone, initial standing, was towards the LAD, would you have chosen a different size?
Well, sincerely, this LAD has an awful dissection. I wouldn't be that aggressive on the LAD, and that was another reason why I went first with the bigger stent on the circ. And remember that the weakest point of this procedure is the restenosis of the ostial circ.
Yeah.
This is why I go with the biggest possible stent.
Let me go back to Chris. I want to ask you something else now. I see that this stent is crossing over the marginal branch, and there is no wire in the marginal branch. So I guess the intention of Flavio is to stent over this vessel, and this is, by the way, also the concern of one of the colleagues. What is your position about this?
Well, number one, it makes a lot of sense to try to stent over the ostium of the marginal, because I think you want to treat this bifurcation anyway. And then the question, adding an additional wire. This would be the third wire. You can do, and you can always add complexity to the lesion. Honestly, I think there will be maybe some pinching of the vessel, but I might have done the same.
Why did you do that, Flavio? Why no wires in the marginal branch?
Well, we did rotational atherectomy. The side branch will not occlude, hopefully. And then if you put a wire on the marginal, you will have the wire engaged for a very long tract. I think that it's very low probability of having this marginal occluded. So I will deal with it after stenting.
The message is, let's not add more complexity to an already complex PCI. Yeah. And I think I completely share this opinion with you. Let's see what you did next. Can you describe the next steps of your procedure?
Yeah, this is the stent deployment. As I said, not going too high pressure. Then there is a pot with a 5.0 non-compliant balloon in the very proximal part to remain in the left main. And then, yes, there is a wire going to the first marginal to do a provisional stenting, just a kissing in between the circ and the first marginal, with a 4.0 on the circ and a 3.0 on the first marginal branch, with the only intention of opening a little bit the struts of the stent towards the left main and not touching it anymore unless it is occluded.
Next, what you did here?
It is not occluded, so for me the oblique marginal is okay, and you can see that I even took the wire out, not to have 3 wires. Now we have to concentrate on this awful image of the proximal LAD. You see that I did another balloon testing. It's a 3O balloon going through the stent struts to the LAD to make sure that I will not have to push or force, in any case, the stent through the stent. And it's a second sotarolimous eluting stent. It's a smaller one, as you suggested. It's a 4O, the same length, 26, covering the dissection and coming into the left main.
The stent looks a little short. Would you maybe have chosen a longer one?
You know, it's, as a religion, I try to put the largest in diameter and the shortest in length. And I mean, it's obvious why. The point that here, with the aim of covering the dissection, I agree with you that the overlapping for the culotte was a little bit too short. So it became to be an unequal culotte. But we will fix this in the end. But I agree, it's not a conventional culotte. It's.
But I think once you have this kind of protrusion, you should proceed also with the culotte, because this is then the adequate technique. Then you need to do the full culotte at the end.
This is what I did. I wanted to have the 2 layers on the more calcified part of the vessel to get more radial force and to expand. But of course, in this case, unless you end up with a reversed mini crash, which I actually don't like that much, I try to make the final kissing and to recross.
Chris, this is the angio result after placing the stent in the LAD. What would you do more here?
Well, I think it looks very good on the circumflex already. Honestly, I think the LAD looks still a little bit underexpanded. So I think we should try to optimize. You can, I mean, I use the pot also in this in this setting, but definitely a kissing and go with at least 3.5 millimeter in the proximal LAD.
Okay, let's see what Flavio did. Tell us what you did.
I agree that the ostial LAD is underexpanded, and what I did was a kissing with a 4O non-compliant balloon on the LAD and a 3.5 on the circle. And this is at a relatively high pressure, which is 16. Depends. For people, high pressure is over 30. I am more respectful of biology, and 30 or 40 atmospheres are something beyond.
The point is your balloon is open.
The balloon is well expanded. The balloon is well expanded. And remember that there is a lot of calcium, is asymmetric, and you have already a nasty dissection of this vessel. So you have to take care of what is, you still didn't finish the procedure.
So this is the control angiography. Chris, now he did what you just recommended. He did post-dilatation on this bifurcation. Are you happy now with the results?
Well, I think it looks better. I think it even looks much better. He even did more than I recommended, because he took a 4-0 balloon, which I think was bold in this setting. Now, if you want to do something more, you can do 2 things. Either you take a bigger balloon, well, bigger than 4O I wouldn't take on this proximal LAD, definitely not. And the next is you can take higher pressures. But what should be the reasoning? I mean, you have a 4O balloon fully opening up. So honestly, I would be done at this point.
How about doing an IVUS control here? After all, it's opened. He had the IVUS on the table. Wouldn't be an option here instead of going further with balloons or just stopping? At least you would take a more informed decision. You know,
we always say we want to know what is the question. And I think in such a complex disease, where you have a result which you say is very acceptable, but maybe you are not sure if you have the full expansion at the ostium of the LAD, I think to use the IVUS as a control if you have full stand-up position makes absolute sense.
What do you do, Flavio, here?
Guidelines recommend the use of IVUS to analyze the final result of an unprotected left main. And we had the IVUS probe already open on the table, and this is an IVUS view of the result obtained so far. You can see on the top still image that it's an elliptic expansion of the stent, which is expected, but an important issue is that the bigger diameter is 6 millimeters. So we managed to get the stent well expanded in the proximal part of the LAD. Then when you go to the left, you see that indeed the ostial LAD is about 3.5 by 3.5. It did not reach the 4, but as you said, expanding the stent larger will require more atmospheres or more balloon, and this will become risky. You see again the uneven elliptic expansion of the stent at the bifurcation, and the excellent result at the point of the bifurcation. I decided not to go for a further expansion of the LAD and to have a look at the circumflex. So you have also an IVUS run. The distal part of the circ is good, despite the large 5-0. The origin of the oblique marginal is open. It's well expanded. Then you see the egg-shaped of the IVUS image on the bottom left image. And then at the highest point, a little bit an asymmetric expansion, but a quite large MLD. So I decided that the intervention was finished.
Actually, there is a very important teaching point here, Flavio, which is not to overdo. You decided at this point that it was the moment to stop PCR optimization and to accept a result which is, by the way, more than acceptable, I would say. It's actually quite a good result. I have a very practical question to you in terms of clinical follow-up of this patient. There is also a question from the colleague. What would be your pharmacologic strategy in terms of dual interpreter therapy?
Well, first of all, I thank you for the quite good result. I tell you, I was very happy with this result. Because in other cases, long time ago, you can try to do more than that, and you have a real risk of having a rupture of the ostium of the LAD. And this will be a real trouble, because if you put a cover stent on the ostium of the LAD and the left main, you will occlude this huge circumflex. And so the result will be very bad. So a very important message that we want to share here is to understand when the result is good, acceptable, more than acceptable, good. I was really very happy with that. And the IVUS gave me also additional information. The point you made is very important. Medical therapy. This patient is 85. This makes him a high bleeding risk, but actually he is not, because he has no other comorbidity except some hypertension that he controlled with blood therapy. No doubt about trying to keep this patient on dual antiplatelet therapy for 12 months using clopidogrel, the less aggressive of the drugs, and monitor after 1 or 2 months. You know that the bleeding happens in the first month. After the 2 months, the patient had absolutely no symptoms. He came back after 6 months. He did a stress test, which is a little bit out of fashion, but he was so symptomatic before that it was very useful to see that he was again fit and training with no chest pain. And we kept this gentleman for 1 year on dual antiplatelet therapy without events, and then with only aspirin, and we have more than 2 years follow-up.
Let me just summarize. With this, I don't want to say that we are at the end of our webinars. Please stay with us, because we still have many interesting points to discuss and interesting things to show you. This is the final angiography that we see in the caudal view. This is the initial still frame, how it was at the beginning, how it is at the end in this cranial view. And this is how it looks like in the RAO caudal view before and after. So we dealt with an elderly patient, very complex case, challenging bifurcation lesion of the left main and a sequential bifurcation lesion of the proximal circumflex. We discussed here the need for hemodynamic support in this case, and we agreed that there was no real indication to have an elective hemodynamic support to start with. We also highlighted the importance of having imaging-guided PCI. And we discussed about rotablation technique, how to properly perform rotablation technique and plaque modification. We ended up with 2 stenting strategy, and we took very wise decision not to overdo and accept a very good result, even if there was some indentation of the stent. Now, my question to Chris would be, do we always need to do rotational atherectomy in distal left main or in calcified left main stenosis?
I think, rotablation is a very nice tool, and it's frequently underused because it can make your life easier, especially in these situations where you have this enormous chunk of calcium. But let me show you another case. And just shortly a situation. I mean, if you look at this vessel, you would say it's a really difficult vessel, and there's also this left main stenosis which you cannot appreciate here. But this is really diffuse disease. If you look closely at this case, you can also see that there is calcium, but the calcium looks different. Number one, it's diffuse. You don't have these really bulks of calcium sitting somewhere. And also the distribution of calcium looks different. So what we did in this case was we took balloons and we tried to dilate with balloons. And at the end we were successful. We started small with 2.5 balloons. We took them up and they all expanded well. So at the end, with very high pressure, we were absolutely able to treat this patient without rotational atherectomy. And you can appreciate here also the not so severe distal left main stenosis, but the diffuse disease on the left circumflex. Now, this is where we were after we decided for a culotte technique in this patient for similar reasons as in the previous case. And this is after we placed one stent in the more distal LAD, one stent in the distal circumflex, and the first culotte stent from the ostium of the left main, similar to the case we've just seen, into the circumflex. Now the problem that you have if you did not rotablate, it could be very difficult now because we need a long stent now from the ostium, almost the ostium of the left main, into the mid of the LAD. We need to cross the struts of the first stent, and we need to go through all these calcium and atherosclerosis, and very often stents could not cross. And this was similar in this case. And I would like to show you how you can manage that very easily and elegantly. This technique is called the GAIN technique, and what you use is a guide liner. Basically, you introduce a guide liner in your catheter, then you push the balloon into the lesion, and you use the balloon as an anchor to forward your guide liner. And once you reach with the guide liner the balloon, you deflate the balloon and push the guide liner over the balloon, advance the balloon again, and repeat this maneuver until you are where you want to be. And once the guide liner is in position, you can place your stent, pull the guide liner back as seen in step 4, and then you nicely delivered the stent. You always center the guide liner with the balloon, and you never interfere with the stent, with the struts of the other stent, or with the atherosclerosis. And I show you how this looks in real life. This is what we did in our case. You can see the stent into the circumflex, and you can nicely see the balloon. And as soon as the balloon deflates, which is now, we move the guide liner forward, and this we did until we finally reached the final position. And here you see the stent, the long stent, which we could easily deliver like this. And here you then see the final result of our case. Beautiful angiographic result. We still have a couple of minutes. I will quickly go through the remaining questions. We addressed already the issue of the 5mm stent in the circ. I don't think we need to go back on this. About the size of the guiding catheter, we recommended 7 French. I think we all agree on that. Laser versus rotablator. I don't have experience with laser. Quickly, any experience with the laser in this case?
No.
No.
Neither do I. Oh.
Then why did you not begin with 1.5mm bar in the circ? We also addressed this one. I think we addressed most of the remaining questions actually. Let's see what else do we have left. The result of this very nice PCI in some months. Any angiographic control follow-up, Flavio, foreseen?
Well, yeah, you are tempted to do that to see how nice it is. But you know, a patient that was so highly symptomatic before with a tight stenosis, if he is performing his physical activity daily with no symptoms, no.
So your threshold for angio would be low, but
no.
You wouldn't do it routinely?
No, I never do. I never do it unless there is something wrong in your procedure, or unless the patient has symptoms.
There must be a clinical reasoning to do it. Yeah.
Thank you very much. I think we addressed all the questions that were remaining. Let me just summarize the key learning messages that we have all conveyed during this webinar. First, have your internal protocol ready, that makes you able to prepare carefully your intervention. Master all tools and techniques to do complex PCI safely, like Flavio nicely did in his case. And you need to know when to stop your procedure. I think this was one of the most important teaching messages we have learned today. We have now reached an end of our webinar on how to safely perform complex percutaneous coronary intervention of distal calcified left main stenosis. I hope you enjoyed the case and enjoyed the discussion as much as we do. On behalf of my colleagues, I would like to organize the PCR team who did an excellent job in organizing this webinar. I would like to thank our sponsor, Medtronic, for having provided unrestricted support. And I wish you to follow up with additional webinars on PCR online. Thank you very much.